Welcome everyone. I'm Dr. Rishika, Assistant Professor working in Lakshmi Narayana Institute of Medical Science, Puducherry. So today we are going to talk about the topic Croup. So everyone used to familiar with what is Croup. So not to waste the time, we will go into the topic proper. So croup. Everyone knows croup is also known as the acute laryngotracheobronchitis. So what is acute laryngotracheobronchitis? So from the name itself, everyone will understand that it is related with some infectious process. So what is croup? Define croup, whatever it is. What if some patient has come to OPD with these symptoms, you need to identify. It can be a croup or not. So it is an acute process which is related to the infection of upper airway structure. So how the child will present with? The child will present with a cough. So the character of the cough will hinge the diagnosis. So it will be like a bark like a raspy cough. So it can be associated with the hoarseness of voice also, and there will be a stridor during inspiration and may or may not be associated with the respiratory distress. So what is a clench here? One is cough, the quality of the cough, and another is a stridor. So everyone knows what is stridor. So stridor, it always denotes a upper airway obstruction. It's just opposite to the V's, right? The V's which denotes the lower airway obstruction. So what is the characteristics of stridor? So it is always a harsh sound. It doesn't like it's not like a V's which is a musical sound. Stridor is a harsh sound which is high pitched, which occur only during inspiration. And after coming to strident, what is beat? Everyone knows it is a musical sound which occurs during expiration, but it goes to severity. It can be also heard during inspiration and expiration. So, croup is a it's always a infection process of upper airway which is acute in onset. The child will be present to you like a bark like or raspy cough associated with hoarseness of voice and inspiratory stridor and may or may not be present with respiratory distress. So who will be most commonly affected with this infection? So mostly we are seeing that toddler age groups will be coming with this symptoms. That is so most common age group which have a higher prevalence of lupus 6 months to 3 years. So most onset peak age will be 2 years. So when it will be affected, it will be affected mostly during autumn and winter season. So mostly the sex prediction doesn't mean that only the male used to get more prevalence of group. The male is more affected than female as per the literature, but everyone can be affected by this infection and will lead to the acute laryngotracheobronchitis. So it is always a mild disease. It doesn't going to cause you a casualty, but even though the severe croup will causes 0.5% mortality even for intubated patients and 1 to 2 percentage of intensive care and only less than 5 percentages of patients are hospitalized. So what it implies means so most of the patient can be treated by OP basis. So already I have mentioned this is caused due to the infection. So what infection is causing this acute laryngotracheal bronchitis? Mostly it is a viral infection than the bacterial infection. So always acute laryngotracheal bronchitis is caused by the viral infections. So most common virus which is causing croup is para-influenza virus, which is type 1 and 3, which constitutes 70% of infection, which leads to the acute laryngotracheal bronchitis. Other viruses which causing croup are influenza A, influenza B, adenovirus, respiratory syncytial virus, measles, and metapneumovirus. So you are sitting in the OPD, you are the medical officer. So one child is coming with a stridor. Then how you will approach the child with a stridor? So it's simple basics. So the child comes with a stridor in your OPD, first you need to analyze whether the child is well looking or sick looking. How do you know the child is well looking or sick looking? If the child is having fever, toxic, it is a sick looking. If child is okay, mild fever or no fever, it is a well looking. So next point, you need to go for the temperature. So coming to the temperature, if the child is febrile, then you need to see whether the temperature is low grade or high grade. Mostly low grade. So what is the causes of low grade uh, causes which leads to the stridor? So one is what we have discussing right now, that is acute laryngotracheobronchitis group. Another one is diphtheria. So group is always caused by viral infection, as I already told you. So always the viral infection will be present with a less toxic, right, than compared to the bacteria. So it is always a low grade fever. The another thing, the patient has stridor coming with a high temperature and sick looking, then you need to suspect you are in danger. You need to be meticulously be with the child. So what are the causes which causes high grade fever in stridor child? It is epiglottis, bacterial tracheitis, and retropharyngeal abscesses. These are always caused by bacteria. And if the child with stridor with no fever, then you need to suspect what is the cause which leads to the stridor. It can be a foreign body. It can be hypercalcemia because of metabolic disorders. Low calcium will causes laryngospasm. So because of laryngospasm, there will be upper airway narrowing. It will causes stridor. And angioedema, the same thing. It is due. It can be due to the allergy or any irritation of the upper airway, which leads to the laryngospasm or a mucosal edema of the upper airway, which leads to the narrowing of the upper airway and leads to the stridor, and neurogenic stridor, which is a rare case. So this is how you need to approach the child with a stridor. So coming to the acute laryngotracheobronchitis group proper. So first, to deal about the group, you first need to know that it is a disease of upper airway structure. So what are the upper airway structure? So there is everyone knows the anatomy of the upper airway structure. So I just want to recollect it. So larynx is always divided into three parts. One is supraglottis, another one is glottis, and subglottis. The part above the glottis is supraglottis, and glottis comprise of vocal cords, and the part below the vocal cord which contains the cricoid cartilage and uh, and the trachea and the subtrachea and other parts of the trachea will lead to the subglottis. So these are the parts of the larynx. So if there is any infection above the vocal cord, then you used to say it is a supraglottitis. So what are the supraglottis structure means? It is a epiglottis and hyoid bone. So any infection of the epiglottis will causes acute epiglottitis. So it is mostly caused by the bacteria infection, and any infection of the vocal cord will causes glottitis, leads to the hoarseness of voice, and below the vocal cord there is a cricoid cartilage and trachea. Infection of this will lead to the acute laryngotracheitis, and if the infection spread below to the trachea and bronchitis, then you will say it is a laryngotracheobronchitis. So if it can you, according to this, you can be classified group as a laryngitis, laryngotracheitis, and laryngotracheobronchitis. So always the laryngotracheobronchitis is severe only because of risk of secondary bacterial infection. Okay. So coming to the clinical features of the group. So how the patients will present with the group. Already I have mentioned you, always the patient will come with a cough. So in the prodromal, it is caused by the viral infection, right? So always the viral infection starts with the prodromal symptoms. So what are the prodromal symptoms which is associated with acute laryngotracheobronchitis? So it can be a coryza, it can be mild cough, and mild fever and pharyngitis. Followed with you need to vigilant to see the upper airway obstruction symptoms and signs. That is classic clinch to the acute laryngocare bronchitis. That is classic of stridor or hoarseness of voice plus or minus respiratory distress. But this group is a mild infection which can be self-resolved. But you need to be explained that you need to be explained to the patient that it can be characteristically worse at night, and it doesn't means that once treated it will goes off. It can be have the recurrence rate which has occurs in frequency, but it is with a decrease in intensity. So always the agitation and crying will aggravate the group symptoms. So basically the child will be so stable. The child will be so stable, but the patient who comes with the child, the patient is more anxious than the child. Then you need to keep in mind you are dealing with the group child. Okay, why it's so? As always, I said strider is a very harsh sound. So the very harsh sound which is coming from the child, every patient, every parents will be panicked. So always the parents will be panicking, but the child, because of this mild viral infection, will have symptoms but doesn't have any features of any respiratory failures or any severe conditions. Thus, the child will present with a brassy cough and stridor with hoarseness of voice. So actually, group is always a clinical diagnosis. So while examining the child, you need to keep in the mind how you are going to approach the child with a stridor. As I already mentioned above, the stridor child, it comes now, if you need to see the temperature. If it is child is febrile, you need to see whether it is a low grade or high grade. If low grade now, you need to suspect group. If high grade now, you need to suspect the more serious condition, epiglottis and uh, retropharyngeal or parapharyngeal abscess, so bacterial tracheitis. So because of this, you need to examine the child who is going to fall into this category. So while group child, coming to the group child, the group child, while looking at the group child, what will happen? The group child will fairly well looking child. As I already said, parents are more distressed than the kids, and you will find the prodromal symptoms. And apart from that, you need to look for the signs of progressive upper airway obstruction. So the signs of progressive upper airway obstructions are tachypnea, stridor, retraction, and the signs of hypoxia. So stridor doesn't mean it should be a loud stridor or strider's free intensity is increasing. The stridor can also be a very uh, very particular sign, because if your upper airway is narrowing, goes on narrowing, what will happen to the strider's intensity will be low, so the child will become has a low frequency stridor, and it will causes leads to the silent chest. So what if the child is going to stridor to the silent chest, then you need to suspect the child is going to the complete airway obstruction, which is more stressed for pediatrician than others, because once the airway is obstructed, the child can't able to breathe, the child will be in a respiratory failure, and child will go for the cardiopulmonary collapse. So always you need to see the these progressive upper airway obstruction in the group child. So what are the, once you are diagnosed the group, then what are the investigation you need to take for the group child? So group is always a clinical diagnosis. If you want to take a investigation, what investigation you will ask the patients to take. So it is a X-ray neck PA view. So in X-ray neck PA view, what sign you will see? It is a steeple sign. Everyone can able to see the narrowing of subglottic area, no? That is a steeple sign. So it is a subglottic narrowing. It is not a pathognomonic for the group. It is an unreliable sign. It may be absent in group also. It can be present in other disorders which is causing subglottic narrowing, and it can be present in a normal population also. So there's no correlation with the disease severity. So it is always a clinical diagnosis where we will diagnose a acute laryngotracheobronchitis. Another investigation what we are going to see, where what we are going to order CBC and CRP because of viral infection. In CBC, there won't be that much of elevated leukocytosis, but lymphocyte predominant can be seen, and CRP is negative or mildly positive. So it is clinical diagnosis is group. So how you will diagnose the severity of the group? It is a by scoring method. Like asthma, we used to score asthma severity by a Croup score or a clinical assessment severity score. Like that group also we are having scoring system for the severity, that is Wesley severity scoring. So what is Wesley severity scoring? You no need to remember all the things, just you need to know there is a scoring system for the group, that is Wesley severity scoring. For your mnemonic, for your easy understanding, there is a mnemonic which means it is a L cars. So what is L? L is a level of consciousness. So if there's a no, the child has no, group child has no level of consciousness, an altered level of consciousness, sorry, normal level of consciousness or altered level of consciousness. So if the child is having normal level of consciousness, it is 0. Altered level of consciousness like disoriented, it is 5. So next scoring is cyanosis. C for cyanosis. If there is no cyanosis, 0. If cyanosis with agitation means 4. If cyanosis at rest means 5. Then A is for air entry. If there is a bilateral air entry is present, which is normal, means 0. If there is a decreased bilateral air entry means 1. And if it is markedly decreased bilateral air entry is 2. So retraction, R is for retraction. If there is no retraction, there is none. 0. If mild retraction, 1. Moderate retraction, 2. And severe retraction is 3. And S is for strider. If no strider, 0. Strider during agitation is 1. Strider during at rest itself, it is 2. So by keeping a score in this mind, we used to score the group child, and if the total score come less than 2 means it is a mild group. It is total score 3 to 7, it is a moderate group. Total score 8 to 11, it is a severe, and more than 12, it is implies impending respiratory failure. So after your clinical symptom diagnosis and scoring investigation, we are coming to the management of group child. So first, my management of group child, for every respiratory condition or every casualty patient, you will see ABC, right? Airway, breathing, circulation. So group is a acute infectious process of upper airway structure. So it can be leads to the upper airway obstruction. So everyone should first start with the airway management, because severe group, it leads to the impending respiratory failure, which is a life threatening. So always you need to be avoid hypoxia. So if you are going to, it is the child comes with impending respiratory failure, you need to secure the airway. Keep in mind, because of infection of upper airway, the laryngotracheobronchial structure will be so much of inflamed, and there will be so much of edematous will be there. So the structure's diameter is reduced. So there will be narrowing of the upper airway. So you need to be choose smaller size of ET tube rather than the corresponding size. Then you need to give a hypoxia management if there is a desaturation or any severe group, you need to give oxygen. No cold mist. Cold mist is advised. So what you will do as a initial management? You are receiving casualty or OPD. First, you need to minimize the agitation. How you will minimize the agitation? Ask the mother to keep the child on this in her lap. So always mother's lap, the child will be so calm, because the child used to think she or he is in safe place. So always examine the child on parent's lap. And if it is a life threatening or if that's a severe group, then you need to administer oxygen. no, and that to be in a non-threatening manner, like a like to non-threatening manner to maintain the oxygen saturation SpO2 more than 95%. And you can postpone IV access unless it's needed, because IV access putting the IV line will agitate the child and it will increases his upper airway narrowing and lead to the severe growth. So no need for IV access means you can just postpone that procedure later, and you should not use any tongue depressor or sedation until airway is secure, because even though clinically you are suspecting the croup, you need to keep epiglottis in your mind. If you are putting a tongue depressor in a child with a severe croup or epiglottis, it will lead to the laryngospasm and the child will collapse in front of you on the table. So never ship the child for X-ray before stabilization. So actually, COOP is a clinical diagnosis. You no need not uh, documentation of X-ray for diagnosing unless it is indicated in other condition. But whatever condition it is, you first need to stabilize the patient. Then you need to shift the patient for any other investigation, right? Okay. So almost we have done the initial management. Initial management is just to secure the airway, then you do whatever you want. So after securing the airway, now you know what child you are dealing with. Either it is mild group or moderate group or severe group, because you have scoped the patient, right? So the child you are dealing with mild group. So the group is always a mild respiratory disease which can be managed OB basis itself. So what is the drug of choice for managing the mild group? It is a steroid. So how does the steroid act? It acts by decreasing the edema by its anti-inflammatory action. So what steroid you will give? You will give oral dexamethasone and nebudesonide 2 mg, which is same at all age. So what is the dose of oral dexamethasone? It is 0.15 to 0.6 mg per kg single dose. Maximum you can go up to 8 mg. So 0.15 to 0.6 mg, this any dose in between this will have the same efficacy. So we always used to put 0.6 mg per kg single dose. So observe for 4 hours after giving steroid, because the onset of action of steroid is 30 minutes and duration is 24 to 72 hours. In after 4 hours, if the child's symptoms decreases, then you can explain the danger signs to the parents, like worsening of the stridor, poor feeding, change in level of consciousness. Then you can send the child to. Coming to the management of moderate and severe group. So apart if the group is severe or moderate group, apart from the steroid, you need to give epinephrine too along with the oxygen. So how does the epinephrine act? What is the epinephrine? The epinephrine mode of action is it is a beta receptor agonist, right? So what will happen? What it will do for this in this condition? In group, normally because of the inflammatory process, what will happen? There will be an increased capillary permeability. Because of increased capillary permeability, there will be an increased mucosal edema. What does epinephrine do? Because of this action on beta receptor agonist, it will do a capillary arterial constriction. So the capillary permeability will be decreased. So mucosal edema will comes down and airway obstruction will comes down and it will relieve the stridor. So this is how the epinephrine works. So how much to give? It is a 0.5 ml per kg of 1:1000 solution, that is undiluted epinephrine. Maximum you can give by 5 ml. So how to give? It is only through nebulization. So how long you will give? You can repeat if no or minimal response, because the onset is 10 to 30 minutes and duration is 2 hours. So after giving adrenaline nebulization, after 2 hours, if you have the same clinical scenario, you can repeat. Or if you have minimal response also, you can. So if it is a severe case, you need, along with this epinephrine adrenaline nebulization and budesonide nebulization, you need to give a frequent dose of steroid for 48 hours. And even though after this management, the child is going for respiratory failure, then you need to ventilate the child and you need to put the child on, intubate the child and you need to give a ventilation. So this is a treatment of croup. So after giving your treatment, you need to assess the child. So by assessing the child, when you will discharge the child. So there is a criteria to discharge the child with croup. The child has no stridor at rest, at least 3 hours since last adrenaline or 30 minutes since steroid given, and normal air entry, normal pulse oximeter, normal level of consciousness, and able to tolerate the oral fluid and non-toxic appearance. The parents are reliable now and they have a good understanding of written precaution. Then you can discharge the child. So coming to the end of the session, everyone knows group is a it is a very common topic. Everyone used to come across once in their life, either in casualty, either in OPD, therapy, in your clinics. So everyone need to identify who is having which child is having the group, and how you need to assess the group and how you manage the group. Okay, so coming to the short recalling section of group. So after diagnosing group and clinical assessment of group severity, we are dividing the group into mild, moderate, severe. So mild group present with the occasionally barking cough. There is no stridor at rest. So what you will do? You will give oral dexamethasone 0.6 mg per kg single dose, maximum 8 mg, and after 4 you will observe for 4 hours. If the child is okay, you will explain the danger signs and you will discharge the patient. If the child is having moderate or severe group, how you will identify moderate or severe group? It is a frequent barking, cough with marked stridor and visible respiratory retraction at rest, and they have a hypoxia symptoms like oxygen less than SpO2 less than 95%. In that case, you need to give oxygen and you need to give a steroid, either oral IM IV. Then you need to give a adrenaline neb, observe for 4 hours. If symptom is improved, is okay, you need to follow the flow chart of my group. You can explain the danger signs and you can discharge. If symptom not improve after this steroid and adrenaline neb, you need to hospitalize the patient and you need to repeat this management and you need to score the child frequently, and once it is improved is okay, but it is going to the impending respiratory failure, you need to manage by intubation and ventilation. So what is the main things we are studying today in this lecture about group? Neither I have discussed about antibiotics or antitussives, humidified air, and heliox. So there is no rule or no literature which implies that you need to use this in group. So no need of antibiotics, antitussives, humidified air, and heliox in the group. And what are the complications you can expect it? So croup is always a mild disease. It can be spontaneously resolved. Only less than 5% of patients need hospitalized. 1 to 5% require the intensive care, and less than 0.5% require the ICU care. So complication is also less. It is 15% due to a secondary bacterial infection and contiguous spread of the infection, which goes to the lower airway infections like pneumonia. So acute laryngeal bronchitis will go to acute laryngeal bronchopneumonia. If it goes, then the complication of pneumonia also comes into that. So what are the other types of group? It is a recurrent group, spasmodic group. So what is recurrent group? It is a 2 or more group-like episodes. So always it doesn't mean that it is always with infection. It associated with comorbidities like asthma, allergies, and gastroesophageal reflux disease. So what is the cause? It's mostly like clinically like less than 10% of subglottic stenosis, reflex changes, and bronchotracheomalacia. So what is spasmodic group? It always occurs in 1 to 3 years of age. No history of any presiding viral illness. and it present with may or may not with allergy component, may or may not with infection. So it mostly occurs at evening or night time, sudden in onset, and it can be recurrent, and there is no signs of any fever. And there is a signs of swelling will be there, but without inflammations. So this is a spasmodic. So coming at the end of the lecture, everyone has come to know about each and every detail about the group. For a short recalling, so croup is an acute infection process of upper airway structure, that is larynx, laryngotrachea, laryngotrachea bronchitis, and the complication will lead to the laryngotrachea bronchopneumonia. So it is always caused by viral infection. That is most common cause of viruses, para-influenza virus, and other viruses like influenza A and B, metapneumovirus, measles, everything. And it is always a clinical diagnosis, no investigation needed unless it associated with other secondary causes like secondary bacterial infection. So it is a clinical diagnosis. The child will present with a brassy cough, barking cough, stridor, hoarseness of voice, may or may not with respiratory distress. And you have scoring system in a group, that is Wesley scoring system, CPRT scoring system. This mnemonic is L CARS, it is level of consciousness, cyanosis, air entry, retraction, stridor, and you need to take a total score, and according to the total score, you will classify the group severity. Then you will manage the child. Initially, you will secure the airway. Then you will mild. If it is a mild group, you will give a oral dexa 0.6 mg per kg single dose and observe for 4 hours. If it is child is okay, then you will explain the danger sign and you will discharge. If it is a moderate to severe group, you will give oxygen, steroid, and adrenaline and observe for 4 hours. If symptom improves, you will manage uh, like same, and you will explain the danger signs and discharge. If symptoms not improve, you need to hospitalize the child and you to repeat the management and give a ventilation. So there is no rule in using antibiotic, antitussives, and humidified air heliox in the group, and there is a very less chance of complication in the group. So thank you everyone for your patient listening. Meet you in another class. Thank you.